I'd like to transition and hopefully bring together the previous talks and also move on to some further discussion of these patient-reported outcomes in pediatrics with a particular focus on work in malignant disease as well as non-malignant conditions like sickle cell. So as I said, we'll give a little background, again, that hopes to tie together some of the previous talks and then get into some of the research and work that I think is relevant to this audience and to expand upon the discussion. So hopefully by the course of the day today, you understand that hematopoietic cell transplantation has largely a curative intent. However, disability is not always prevented or halted by transplant. And of course, this is a multimodal issue with many domains and factors at play, but at the core is the disease for which the individual is being transplanted itself, and any potential comorbidities or other factors related to that disease itself. For example, in the case of sickle cell disease, there are end-organ toxicities that persist despite transplantation, as well as for those getting transplant for malignant disease, some of the transplantation chemotherapy can also influence those outcomes. And that also segues into the treatment-related effects and the impact that those can have on various domains in terms of patient-reported outcomes. But as you see here, they all intersect. There's no distinct framework or mode that these domains affect individuals and can encompass a host of areas, whether that's physical function and mental health, which you've heard about, but also more factors like education, or even in pediatrics, we focus on transition. So for example, the transition from pediatric care to adult care, but even transitions in geography and locations of care, as well as more related some impact on education, employment, insurance, and income. And we'll delve into these in more detail. But when it comes to pediatrics, there are some specific issues that create complexity in assessing patient-reported outcomes. I think the most obvious of which are the developmental issues related to assessing patient-reported outcomes in this population. In particular, children often are unable to articulate some of their needs, and this may actually delay early intervention services, thereby exacerbating potential psychosocial factors. In addition, there are age-related variations in vocabulary and comprehension that make it complicated and even difficult to design a tool or a measure to assess these patient-reported outcomes in children. And then lastly, frequent hospitalizations, medical visits, and subsequent school absenteeism could negatively or adversely impact psychosocial development. But the other area that I want to highlight is this sort of dual responsiveness that often comes when you're dealing with pediatric patients who are dependent and thereby often function in a dyad of a patient and a caregiver. And so when assessing patient-reported outcomes in this population, often you'll have a mixed or a dual set of responses that include primary responses, largely from children who are around age 7 and up, or caregiver proxy responses, where the parent gives their response to how they feel their child is doing on certain measures. And then again, the caregivers often convey information about their child, giving secondary information on their own, but there's limited information directly about how the caregiver is impacted, which again, when you're functioning in a dyad, is also important. Nonetheless, we do have a number of measures to look at patient-reported outcomes and quality of life in children, one of which you heard about before, the PROMIS measures. But also there's the PEDS-QL, the EuroQ 5D, which is available in 5 languages, the Beck Youth Inventory, and a whole host of other patient-reported outcome measures that look at either overall measures, disease-specific measures, or even symptom-based measures. But this only scratches the surface in some cases, and it's important that we actually go to patients and families to determine what other aspects of quality of life and health need to be gained. And this highlights work done by Burns et al., in which I collaborated to actually bring in patients and caregivers into a discussion of setting a patient-centered outcome agenda. And we divided the work up into 6 distinct working groups, the first being patient, caregiver, and family education support, then sexual health and relationships, physical health and fatigue, emotional, cognitive, and social health, models of care delivery, and lastly, financial burden, which I'll delve into in a little more detail later. But I think the most important thing that we were able to do with this work is give these patients and families a voice in their care. And this next slide just sort of highlights some of the takeaways from this study. It allowed patients to understand what the transplant road could be, gave a sense of community, also gave an opportunity to better delineate experiences for other patients in the future. And it exposed, excuse me, those participating to information of which they did not know. And I think that'll be a recurring theme. But for me, the biggest takeaway was a quote from one of the patients who stated, "We thought we'd go through the transplant process and get back to our life, and it's been everything but that." And I think this statement speaks to the importance of our need to better understand the quality of life and disability and other outcomes associated with transplantation. Now, one of those domains is financial burden, which to some of you may seem odd when we're talking about pediatrics, but I think that can be the potentially largest impact of this, not only on the patient, but also on the caregiver. And in particular, in terms of the patient, your schooling and education sort of serves as the foundation of your future financial potential. And any impact on memory and attention or restriction in social function, whether that's due to body image concerns after transplant or because of social isolation during the early phases of transplantation when your immune system is at risk or naive. Also, individuals, whether it's the caregiver themselves or even the patients, have difficulty gaining employment in the future. Again, whether that's related to previous school-related concerns, or often a desire or need to actually find employment that provides healthcare coverage so that they continue with their survivorship care or with other aspects of their care, or having a provider that remains in network when they've established a medical home. The other nuance in pediatrics is that the lapses in coverage or benefits that can occur. This is typical for many in the annual enrollment phase, but also when patients transition from pediatric to adult, there's often a loss in insurance coverage. And how do we navigate that and prevent that as a barrier to healthcare? The other particular nuance that can occur, especially in individuals transplanted with chronic non-malignant diseases like sickle cell, is the transplant has in effect cured them of that disorder, which then sometimes makes them ineligible for certain benefits based on that diagnosis, even though they may carry some long-term sequelae of the disease. And I think last but not least, again, which may be surprising when we're talking about pediatrics, is the issue of reproduction. However, fertility or loss of fertility is one of the major concerns of patients and parents as they're pursuing transplantation. And this is a very costly procedure, not only to preserve fertility, but also down the road to look into reproductive assistance, especially when we're talking about children who may not use those services for another 10, 20, or even 30 years. Regrettably, though, there are very few patient-reported outcome measures that are validated and able to be used in this patient population, and specifically looking at transplantation. So what our group has set out to do is actually design a validated measure that not only captures traditional financial burden in terms of what is your income and what is your insurance, but also the negotiation between meals and medication, or the decisions that families have to make around other sources of income, childcare, and all of the things that can impact the household income and the sense of financial hardship. And what we were able to find in validating this tool is that, one, individuals could consistently define key terms like household income, health, financial hardship, and quality of life. We also determined that the survey itself was sufficient to allow participants to convey the financial impact of transplantation. But again, we did see that participants were unaware of many financial resources. And now I think in talking about financial burden, this is a good segue into social determinants of health, because we're speaking to some of the aspects of economic stability that can be at play. But there are other factors like the neighborhood and physical environment, education, food security, community and social context, as well as healthcare systems that can also influence your health and health outcomes, in particular when we talk about mortality, morbidity, and life expectancy. And I now want to highlight a couple of studies that I collaborated with in the transplant population to look at these social determinants of health. The first was a study that looked at two cohorts of pediatric patients over a 10-year period of time that really received allogeneic transplantation. And the majority of those patients were recipients for malignant disease like leukemia or lymphoma, with a host of non-malignant patients as well, which includes things like sickle cell disease and aplastic anemia. And unfortunately, what we found is among those with malignant disease, neighborhood poverty conferred an increased risk of transplant-related mortality, meaning death associated from transplant. And in secondary analysis, Medicaid insurance was associated with inferior overall survival and, increased transplant-related mortality compared to private insurance. And when we looked at a similar, at another population of both adult and pediatric patients with sickle cell disease, we found similar results. Of the patients with Medicaid insurance, those individuals had lower event-free survival and higher graft failure compared to those with private insurance. This suggests that economics are at play and have a substantial role in not only the patient's experience, but also their outcomes of transplantation. It also has the potential to create health disparities. In essence, we're seeing individuals with a heavier burden of illness or injury, disability, and in this case, mortality, given comparable biology and health needs with similar social and economic environmental factors. So how do we balance the scales so as to not tip towards a disparity in health after transplantation? And I think, one, we need better tools to capture these outcomes, in particular financial burden and hardship, because as we've seen, poverty and insurance status influence transplant outcomes, and it has the potential to create healthcare disparities. But ultimately, this research enables program developers and policymakers to make better decisions in allocating resources so that ultimately we can reach the goal that we all hope to attain, and that patients live life more fully. And in summation, healthcare needs continue after transplant, whether that's survivorship or whether that's other aspects of chronic disease care, and that health-related disability and financial burden intersect, and that resources must be well publicized and communicated in ways that consider health literacy, advocacy, and public outreach so that our patients and families have access to the resources and tools they need.